Hello, everyone, and thank you for being here for chapter 21 and 22. From here on out, for the rest of the semester, we're going to be discussing specific diseases of certain areas of the body, and chapter 21 and 22 will kick it off with the skin and eye and respiratory infections. We'll begin with chapter 21 here. And first, let's talk a little bit about the structure of the skin. The skin can be broken down into essentially two main layers of cells. First, the epidermis, and this is the very thin, relative to the other layer, outer layer of dead cells and keratin. And then the dermis layer is the thick layer that can be seen in the image to the right, which is this inner layer of connective tissue. In addition to those layers, there's also the presence of hair follicles, sweat glands, and oil glands. And the condition of skin tends to be dry. It tends to have a lot of salt content, and it is slightly acidic. And these are all very important attributes to skin, as it is one of the first line of defenses that we spoke about in the prior chapters. Again, if you may recall, some of these physical factors are the skin and mucous membranes, maybe the lacrimal apparatus, the ciliary escalator, earwax, urine flow, vaginal secretions, and others. And so we're going to focus in on this particular tissue. And as you may recall, the sebaceous glands are responsible for producing an acidic and oily film on the skin surface. And that helps to prevent microbial growth. And you may also remember that there is a normal microbiota that exists on the skin. And that normal microbiota helps, is made up of beneficial, in general, beneficial microbes that live on the body and help protect it from harmful pathogens through competitive exclusion, the production of antimicrobial compounds that might inhibit growth of other microbes, and it also helps to promote the development of a healthy immune system. Now, included in our normal skin microbiota are microorganisms like Staphylococcus and Micrococcus. And the organisms that inhabit our skin, they tend to be resistant to the desiccating, the drying surfaces of our skin, as well as halophilic, which you might remember means to be a salt-loving microbe. There are parts of the body that can trap perspiration, such as the armpits, and those regions tend to grow a more diverse and larger number of microbes. And there are some microbes that only grow in the hair follicles, which are a very unique microbial climate or environment compared to the general aerobic surfaces of our skin. There are many different types of microbial diseases of the skin that may come from bacteria, fungi, viruses, or parasites. And we're going to take these on one group at a time. First, starting with the bacteria, we'll look at microorganisms that are involved with skin infections, whether it's Staphylococcus, Streptococcus, Pseudomonas, or other microbes that cause acne. Staphylococcus, as their name suggests, are spherical, and they occur in clusters of growths, and they're also gram-positive bacterium. They are facultative anaerobes, which allow them to grow both in the aerobic environments of the skin as well as in the anaerobic environments that might be found in the pores, hair follicles, and sebaceous glands, as well as wounds where there is much less availability of oxygen. Staphylococcus bacteria are therefore commonly responsible for bacterial skin infections. Some Staphylococcus species produce an enzyme called coagulase, which we covered earlier in the semester as an enzyme that can cause blood clotting. And this creates a protective barrier from the immune system. However, not all of them do this. An example of a coagulase negative species, so that's a species that would test negative for the production of coagulase is Staphylococcus epidermis. This bacterium is the most common of the Staphylococcus and maybe the most common bacterium on the very outer surfaces, outer facing surfaces of the skin's microbiome, making about 90% of the population. And this is where it exists, typically just harmlessly. And it only becomes a problem if the skin barrier is broken, and that can allow them at times to cause infections. And so we would refer to microbes that have this sort of a pattern of typically being harmless, just part of our normal microbiota, but occasionally may cause a disease under certain specific conditions, but not usually. We would call those opportunistic pathogens where the opportunity arises. And the fact that it's only really infecting through when the skin is damaged, that again is called the parenteral route. On the other hand, Staphylococcus aureus is coagulase positive and is considered the most pathogenic within the genus. It is a permanent resident in the nasal passages of about 20% of people, and roughly 60% carry it transiently, so temporarily here and there. And it's able to colonize the body without causing any immediate disease, and it can be persistent, but it can also at times be a very dangerous organism. So understanding these bacteria can help us understand the role that these microbes can play in our human health as well as causing potential diseases. Interestingly, the Staphylococcus aureus genome is a whopping 300,000 base pairs larger than Staphylococcus epidermis. And those extra genes often encode virulence factors that make Staph aureus more pathogenic. Some of these factors help it to evade the immune system. So, for example, protein A is capable of binding to that constant region of antibodies called the FC region that does not change between different antibodies that are specific for different antigens and define the class that antibody belongs to. And what this does is it kind of is grabbing the animal by the tail, so to speak, away from the biting end. So the animal being the antibody, it prevents that antibody from attaching with its antigen recognition region. And therefore, recognition by the immune cells is not the following process there. It also produces toxins that kill phagocytites, which are a set of our immune cells that go around consuming bacteria that may cause infections. And so it has these mechanisms to survive inside of those phagocytes, even when engulfed by producing certain toxins. Beyond immune evasion, Staphylococcus aureus neutralizes antimicrobial compounds produced by the host. Its cell wall, for example, is resistant to lysozyme, which we covered before as being an enzyme that we produce in our tears, in our saliva, and even in our perspiration that helps break down bacterial cell walls. So, antibiotic resistance is also quite common in Staphylococcus aureus, making it hard to treat infections as well. And so, these are examples of why Staph aureus is much more dangerous than Staphylococcus epidermis. And in this image here, this is showing how that lysozyme, that's an important antimicrobial that we produce, acts on peptidoglycan in the cell walls of bacterium. It actually is responsible for hydrolyzing the bonds between NAM and NAG. Now, you can think of a hair follicle as a tiny fortress, and it's usually pretty secure. It keeps out bacteria. But all it takes is a small breach in that hair follicle, maybe a scratch, a blocked pore. But there are certain right conditions that allow for bacterium to infect the area. In particular, Staphylococcus aureus is one of those bacterium where the trouble starts. At first, it's just can start out as what we call as folliculitis. And whenever you see itis attached to a word, itis means inflammation. So folliculitis is inflammation of the follicle, and its root cause, pun intended here, is a mild infection. A little red bump can form maybe some irritation, but if the bacteria keep multiplying and pushing deeper, the infection turns into what we call a furnicle, or what most people may call a boil. Now, this is more swollen, painful, and we're getting to get more, it begins to be filled with pus, and your body now is kind of in full defense mode here. And if Staph aureus isn't stopped there, it spreads beyond that original follicle and it links up with other neighboring infected follicles. And then it forms what's called a carbuncle. This is a much larger infection that can trigger fever and make you feel sick all over. And so we can see how this can start off with a minor invasion and can turn into a full blown and spreading infection. Staphylococcus is the most common cause of a disease called impetigo. This is highly contagious as a skin infection, and it spreads quite quickly, especially in children, young children between the ages of 2 and 5. It usually starts out as red sores, and it can turn into sort of a honey-colored crusts that form. You can kind of see that in these images here. But S. aureus doesn't just stop here. In some cases, it can produce exotoxins, and those toxins break down proteins that hold the tissue of the skin together. This leads to what we call as scalded skin syndrome, which you can see in the image to the right here. This is a severe form of impetigo where large patches of skin blister and peel, and it's almost like a burn. And so it all starts with this very common bacterium that is capable of producing, certain strains are capable of producing those exotoxins. When looking at streptococcus under the microscope, the first thing that you will notice here is that they are also spherical and gram-positive, but they're not. As you notice, they don't grow in clusters. They're not like staphylococcus. They're streptococcus, which means that they grow in chains. But what really sets each type apart is how they interact with red blood cells. And so, an easy way to remember this is the ABGs of streptococcus. And this has to do with their ability to secrete hemolysins. And lys again means to break apart, and heme has to do with the blood. So, A for alpha hemolytic. These bacteria only partially break down red blood cells, and they leave behind a kind of greenish tint on blood agar. B is for beta hemolytic. These are the most dangerous ones. They completely destroy red blood cells, creating clearing zones on blood agar. Beta hemolytic species tend to be the most pathogenic. And then G is for gamma hemolytic, where there's no hemolysis at all. These bacteria don't produce hemolysins, so the red blood cells remain intact if you were to grow these on a blood agar plate. So if you ever have to remember, again, it's the ABGs of streptococcus, and I always remember B for beta and B for bad. So that's the worst one and the most aggressive of all three types. Group A, beta hemolytic, streptococcus pyogenes, doesn't just infect, it also can evade the immune system, it can spread and take over very well based upon a set of powerful virulence factors. And so we're going to go through several of these mechanisms that it does this. One is the M protein, and this blocks the immune system from recognizing the bacterium and stops phagocytes from engulfing them. The M protein binds to this molecule in our skin called the fibrinogen. And this covers the bacterium and prevents the immune system from tagging it for destruction. So it acts as a mask or a tissue disguise for that bacterium. Hyaluronic acid is, as you might be aware, is a common chemical present in our skin. We've discussed that when we talked about antimicrobials or toxins that antimicrobials and microbes can produce, and they can actually take the hyaluronic acid and form a capsule with it. Since human tissues also contain hyaluronic acid, guess what? This means that the capsule lets the bacteria blend in and also helps evade our immune system and evade antibody detection. They also produce some enzymes here. So they have special enzymes that allow for breaking down host tissues. And as you break down the tissues, that allows the bacteria to invade and spread throughout the body. So putting together these different factors that makes Streptococcus pyogenes particularly virulent. Now we're going to move on to Pseudomonas aeruginosa, and you're going to see how it looks a little bit differently here. It's kind of set apart from the ones we've discussed so far. It is also just an opportunistic infection, but it can be pretty nasty at times. This organism actually thrives best in moist environments. And in contrast to Streptococcus and Staphylococcus, it's actually gram-negative and it's rod-shaped. Pseudomonas bacteria are able to survive also in low oxygen environments. It's not something you need to remember here, but they actually can use nitrate as a terminal electron acceptor instead of oxygen. Pseudomonads are highly resistant to antibiotics and are typically less sensitive as a gram-negative bacterium to beta-lactams, which is a choice drug for treating gram-positive bacterium. And they can cause a whole range of different skin conditions. For example, taking a dip in a poorly chlorinated pool or hot tub can later lead to itchy red bumps that show up, and that's Pseudomonas dermatitis. This is a rash caused by Pseudomonas aeruginosa, and it appears as papules, which are little swollen red marks without any pus present, or pustules, which, as you can imagine, is where pus is present. The good news is this is typically self-limiting, and what that means is it usually clears up on its own um, in a relatively short amount of time. It doesn't linger for too long, about a couple of weeks. If it gets into the ear canal, it can cause otitis externa. This is also better known as swimmer's ear. This infection leads to pain and swelling and sometimes drainage as bacteria work their way towards the eardrum. And left untreated, this can become a serious issue. In severe cases, especially in burn wounds or surgical sites, Pseudomonas can even invade deeper in immunocompromised individuals as well. It can lead to necrotic skin lesions. And it also has the ability to form biofilms and produce toxins. And as you can imagine, that makes it difficult to treat. Pseudomonad skin infections are a common cause of hospital-acquired infections. So infections that patients who are lingering around in the hospital can contract. We also there's a technical term for that, and that is nosocomial infections. And these typically occur and are isolated from patients who might be spending more than a week in a hospital. Commonly, these nosocomial infections from pseudomonads occur in second or third degree burn patients. And again, they are capable of forming biofilms, and so they often will coat the surfaces of medical devices such as catheters, and they are hard to flush away. And so that can be a reason why they're so common for nosocomial infections. Acne is the most common disease out there, and in the US alone, about 50 million people annually deal with it. More than 85% of teenagers will experience it at some point. So, what's actually happening here? Well, it all starts where shed skin cells and sebum clog hair follicles. And normally, skin cells slough off and moves freely, but when things get backed up, pores become the perfect breeding ground for bacteria, leading to inflammation and breakouts. Acne comes in three main types. Uh, let me pull them up here. Comedonal acne is when pores are clogged but not inflamed. Think of blackheads and whiteheads. Then you have inflammatory acne, where the immune system gets involved, leading to a red, swollen pimples like papules and pustules. And then there's nodular cystic acne. Let's show some examples of that here on the next slide. So, again, acne is not a one size fits all. It comes in different forms, and how you treat it depends on what is causing it, or how um, spread it is. An easy way to remember these three is the acronym COIN, or COIN, comedonal, inflammatory, and nodular cystic. Let's just back up here and start with the first one. So, comedonal acne. This is a mild type caused by physical blocking of hair follicles with dead skin and oil. And not really much bacteria there, just blockage. And so, as far as treatment, you can use topical agents, retinoids that help speed up cell turnover, or salicylic acid, which helps to clear out pores. Now we're getting into more of like a disease state. So, I is for inflammatory acne. This is when bacteria, specifically bacterium that's very common in pores, called Cutibacterium acnes. So it's formerly called the Propionibacterium acnes. It metabolizes sebum and it triggers inflammation, and the result are these red swollen pimples. Treatment usually is just some antibiotics to kill the bacteria, or drugs that reduce oil production. And the most severe case or type is N for nodular cystic acne. It's a progressive form of inflammatory acne where deep, pus-filled lesions from under the skin form. This isn't something that clears up usually just with regular treatments. Things like Accutane, which is isotretinoin, is often the go-to because it drastically cuts sebum production and reduces inflammation. So when it comes to acne, remember COIN, comedonal clogs, inflammatory infection, and nodular cystic needs Accutane. Okay, moving right along, we have viral infections. And we'll start from the top there with warts, which are typically benign skin growths, and they're caused by the virus called papilloma virus. Once infected, the incubation period is typically multiple weeks, and different papilloma viruses are responsible for infecting different parts of the body, whether it's plantar warts or warts that form on the hands and other places, which we'll discuss in another chapter. And they are typically treated, these ones that are found on the skin are typically just treated by freezing them off, using some sort of a drying agent, topical acids, or lasers. Smallpox was not just another viral disease of the skin. It was actually one of the most deadly infections in human history. It's caused by the variola virus. The variola virus has two forms, variola major and variola minor. Major was the worst. In adults, it killed 20 to 60% of those who got infected. In children, the mortality rate would reach about 80%. Variola minor was the milder form. The mortality rate was less than 1%, but that's still actually pretty dangerous. Um, the virus enters through the mucous membranes of the respiratory system, usually through inhalation. From there, it spreads systemically, and it eventually reaches the epidermal layer, where it causes the hallmark pustular lesions, which are very painful, fluid filled sores that covered the body. And for centuries, smallpox devastated populations. But thanks to a very aggressive global vaccination campaign, smallpox became the only human disease ever eradicated worldwide. I think we're on our way with another one, Loa worms, or there's another parasite that we've almost gotten rid of. Um, but it was completely wiped out by about 1980. And the next is chickenpox and shingles. So one virus, two diseases. And that's how varicella-virus, also known as human herpes 3 or HHV3, works. First, it causes chickenpox, and later it can return as shingles. Chickenpox starts when the virus enters through the mucous membranes of the respiratory system, usually through inhalation. It spreads throughout the body for about 2 weeks, then it settles in the skin, where it causes itchy vesicles and eventually ruptures and scabs over. Um, Now, HHV3 doesn't leave the body after chickenpox clears. It's a retrovirus. And so it actually integrates its genome into the nerve cells and hides there in the dorsal spine cord region. And it can stay there latent for years. Most people, it's going to stay completely silent. But when your immune system weakens, often due to aging or stress, things like that, it can be reactivated as shingles. And this time, instead of a full body rash, it usually follows that dorsal spine nerves around the waist there, as you can see here along the waist, and usually along on one side. Herpes is the next one to discuss here, and it's abbreviated. It stands for herpes simplex. HSV stands for herpes simplex virus, and there's two main types: HSV1 and HSV2. HSV1 is like we discussed with warts. They tend to have a specific area that they like to grow on. So HSV1, it's referred to as oral herpes. It's primarily transmitted orally, but it can occur around the genital region as well. And there are some pretty interesting stats out there that say about 90% of the US population is infected. Really just depends on what figures we're looking at here. Most people with these infections are asymptomatic, but some manifest as temporary vesicles at margins of lips, and this is what we call cold sores. Now, HSV2, this one is transmitted primarily sexually, and most infections are asymptomatic, but some can manifest as temporary vesicles called blisters in the genitalia regions, although it can occur in other areas like orally as well. The next virus we'll discuss is the measles morbillovirus, and this is also known as rubeola. This is extremely contagious. It's very dangerous for infants and the elderly. Its portals of entry include mucous membranes, the respiratory system, and it's characterized by a rash that starts on the face and spreads to other parts of the body. But largely, this isn't too much of an issue these days due to the vaccination schedules of children. And actually, for that matter, I did not mention that the same is true for smallpox, and we're getting there with HSV2 as well. Rubella, also known as German measles, as it was first described by German physicians in the mid 18th century, is caused by rubella virus. Its port of entry is mucous membranes of the respiratory system, again, and it causes a systemic infection characterized by a rash of small red spots. That's what rubella in Latin means, is a small little red. It has mild symptoms and low mortality. Contraction during the third trimester can cause congenital rubella syndrome in 35% of cases, and this can lead to deafness, cataracts, heart defects, mental retardation, and even death. And that covers our viral skin diseases. Let's go over fungal skin diseases and parasitic skin diseases pretty briefly here. Fungus isn't just something you find in old bread. They can invade human tissues too. So cutaneous mycosis affect the hair, nails, and surfaces of the skin. Tinea or ringworm, despite the name, is not actually a worm. This is a fungal infection that spreads in a circular pattern, as you can see in that top image. It's highly contagious, spreading through contact or contaminated objects like fomites. You can get it from pets, towels, gym equipment, etc., etc. Some fungal infections go deeper, so subcutaneous mycosis don't just stay on the surface, and they actually penetrate deeper into the dermis. These infections are usually caused by soil fungi, and they enter the body through skin wounds like cuts or punctures, the parenteral route. They're less common than cutaneous infections, but can be much harder to treat. Okay, candidiasis is caused by the dimorphic. That means they can be in both a multicellular mycelium form as well as the single cellular yeast form, as shown in this image to the right. This Candida albicans can be found on mucous membranes. It can cause vaginal candidiasis. We've discussed that. Oral candidiasis, also known as thrush, shown in this image on the bottom here, and systemic candidiasis, although that is more rare. It is most common to occur after a bout of antibiotic treatment that treats bacteria, knocks out the bacteria, and then you can have this yeast, which no longer has that normal microbiota keeping it in check, and it leads to a superinfection. It can also occur in immunocompromised individuals. We have one final group of microbial organisms that causes diseases of the skin, and that is the parasitic organisms, namely lice. Lice are a specific microbe called Pediculus humanus capitis, and these insects have legs that are adapted quite well to their environment. As you can see in figure A, they have legs for grasping onto the hairs of humans, and they colonize the scalp and they feed on blood. Now, they are highly transmissible, and actually, they're primarily transmitted through direct contact, and they can be easily treated with topical insecticides and or mechanical removal procedures that use something called a nit comb. You probably have heard of the term nitpicking or being a nitpicker, and that actually is derived from the process of removing the nits, which are the eggs of lice. That wraps up our conversation of microbial diseases of the skin. Let's go ahead and switch gears now and talk about a couple of the eyes. And again, this will involve the lacrimal apparatus, which is just the structure of the eye that's associated with generating tears, releasing them to the eye, and draining them. And the most common eye infection that occurs is bacterial conjunctivitis. Another name for that is just simply pink eye. Again, it's the most frequent kind, and it gets its name from the fact that you typically have red eyes and inflammation from this. The junctiva is actually the thin, transparent membrane that covers the white part of the eye called the sclera and the inner surface of the eyelids. And you can see signs of this through redness, inflammation. It's sticky, and you get this sort of pus-like discharge. And that's really important in diagnosing it as a bacterial form of conjunctivitis. That is actually indicating that there's bacterial growth in there, just kind of like a culture. Symptoms may include blurred vision, eye pain, light sensitivity, and it can be caused by a lot of different bacterium. We're going to be cover these again when we look at respiratory diseases that cause. They can also infect the middle ear. That's otitis media, but they're Haemophilus influenzae, Staphylococcus pneumoniae, Streptococcus aureus, and M. catarrhalis. Now, it is pretty contagious, but it usually resolves on its own within a few days. So that's what we call self-limiting. However, sometimes topical antibiotics are prescribed to help treat it. The other one is viral conjunctivitis. And as you can imagine, this is caused by viruses, most commonly viruses within the adenovirus family. There are other viral causes. This might include HSV or VCV and some enteroviruses. And it can occur alongside common colds, the flu, or upper respiratory infections. The symptoms are very similar to bacterial conjunctivitis. However, again, that discharge, it's not turbid looking in appearance, not like a pus like appearance. It's rather just watery in appearance. And the symptoms for viral conjunctivitis usually resolve themselves in just 1 to 2 weeks. And that actually is going to wrap up our conversation for skin diseases and eye diseases. And that wraps up chapter 21 on skin infections. We're going to now move on to respiratory infections. Now, the respiratory system can be broken down into two main categories: the upper respiratory system that can start with the nasal cavity, the sinuses, down to the larynx, and then the lower respiratory system, which is going to be demarcated between the larynx and the trachea. So from the trachea down to the lower lobes of the lung. As we take a look at the anatomy here of the upper respiratory system, we're going to generally follow the path that air takes as it enters the body and moves towards the lungs. So air can enter through the sinuses, entry through the nose and the sinuses. The air enters where it's warmed, it gets humidified and filtered through the sinuses. There are air-filled spaces in the skull, and they produce mucus, and that helps to trap dust and microbes. Passing the tonsils and the pharynx, air moves deeper. The tonsils contain immune cells, and that helps detect and respond to pathogens. And next, it reaches the pharynx or the throat, which is a shared passage for both air and food that has to direct them to the correct area for each. Before air enters that lower airway, the epiglottis is a flexible flap of tissue, and this ensures food and liquids don't enter the respiratory tract, or as we say, go down the wrong tube. Just beyond this is the larynx, and that's your voice box, which houses the vocal cords and allows sound production. The trachea and esophagus are the two other regions that I will talk about. The larynx moves air to the trachea, and that's sometimes referred to as the windpipe. And this is a cartilage-supported tube that directs airflow to the lungs. Now, parallel to the trachea is the esophagus. And so if it's parallel to the trachea, it's not involved in taking air to the lungs. This is where food and liquids and mucus or whatever else gets diverted that's not air away from the lungs and towards your stomach here. And then the air actually can continue into the lower respiratory system where you have gas exchange, so on and so forth. Okay. And then I will just briefly mention here back at the top, this isn't really following the airflow, but another area of concern is this auditory or Eustachian tube here that runs along the inner ear here, and that's important as well. As we've learned, that's an area that can get infected. Again, if you see itis at the end of the word, it means inflammation, usually caused by infection or irritation. So pharyngitis, this is inflammation of the mucous membranes of the throat, what most people call a sore throat. Laryngitis, as you imagine, is inflammation of the larynx. This one messes up your ability to speak, makes your voice sound hoarse or even temporarily gone. Tonsillitis is inflammation of the tonsils. Those are lymphoid tissues in the back of your throat. They can swell up and make swelling painful. Sometimes a doctor might feel them to see if they're swollen as an indication of an upper respiratory tract infection. Sinusitis is infection of those sinuses, and it can lead to a buildup of mucus, pressure, and congestion. Sorry. And then epiglottis is the most serious. This is inflammation of the epiglottis, which is that flap that covers the windpipe. And if it swells too much, that can block the airway and make actually a medical emergency. So we're going to focus on just two broad categories here for the upper respiratory system. We have bacterial infections and viral infections. Let's start with bacterial infections with streptococcal pharyngitis. This is also known as strep throat in the business. It's caused by the group A streptococci, again, so Streptococcus pyogenes, that are often resistant to phagocytosis. And they can evade phagocytosis by producing these compounds that we've talked about before, streptolysins and streptokinases. Streptolysins make pores in the membranes of the phagosome, and streptokinases attach to the phosphate groups of the lipids in the phagosome and disrupt the membrane, so they aren't digested. And they can cause inflammation of the pharynx and a good fever. Typically, they're accompanied by tonsillitis. You can see in the back, these tonsils are very swollen, this poor person, and swollen lymph nodes in the back or of the neck. Typically, this is just treated with penicillin. You catch it early, it's usually not too big of a deal, to be honest. And quite often, strep throat, a mild form of it, can be self-limiting. Streptococcal pharyngitis, better known as strep throat. Now, we have this other kind here, which can be streptococcal pharyngitis with a lysogenized Streptococcus pyogenes. Remember that when a virus integrates into a bacterial genome, and in this instance, it carries with it a gene, it can transform that bacteria to have a new trait. In this instance, it carries a gene that synthesizes erythrogenic toxin. And this allows that bacterium to synthesize that protein, which leads to this condition called scarlet fever. So, along with the usual sore throat, fever, swollen lymph nodes, this toxin causes a pinkish red skin rash that feels like sandpaper. And another key sign is that the tongue starts off with red spots and it later becomes enlarged and bright red, often called a strawberry tongue. Scarlet fever isn't always linked to just throat infections. It can develop into a streptococcal skin infection, but either way, it's caused by the same toxin-producing strain of Streptococcus pyogenes. Corynebacterium diphtheriae is essentially harmless. It can still colonize the throat, but it won't cause diphtheria because it lacks the toxin. Diphtheria is caused by C. diphtheriae, but not just any strain, only those that have been lysogenized by a bacteriophage that allows them to produce a potent exotoxin that damages tissues. One of the key signs is a leathery, grayish tongue. Let's see if I have it here on the next image. This is a fibrinin dead tissue that forms in the throat. This pseudomembrane can make breathing and swallowing difficult. Before 1935, diphtheria was a leading infectious killer of children in the U.S. but today it's rare, and that's thanks to the DTaP infection, D for diphtheria, which protects against diphtheria, tetanus, and pertussis. Next up, we're going to talk about otitis media. This is earache infection of the middle ear. It can be caused by a number of different microbes, S. pneumoniae, H. influenzae, M, uh, which stands for, Moraxella catarrhalis, S. pyogenes, or viruses. And if it gets serious, it can lead to pus buildup, and that puts pressure on the eardrum and causes inflammation. This is more common among children. Why? Because the auditory tube is smaller and it's more horizontal, and that can actually lead to a poor drainage than experienced in adults. Next is viral infections, the common cold. In fact, this is a upper respiratory tract viral infection. It's caused by more than 200 viruses. However, 30 to 50% of them are rhinoviruses, 10 to 15% are coronaviruses, although maybe that's punched up a little bit higher since we've had COVID-19. The optimal temperature for a rhinovirus is that of the upper respiratory system, so that's why it's more commonly found there. There's a correlation found between cold weather and incidence of colds. It's not very well understood, but the concept here is that scientists believe that when the viruses are being transmitted from one host to another, they obviously can't survive and do their own thing outside of the body, right? They need to infect cells to have them do their metabolism and their replication. So the key is survival for as long as you can. And the idea is that cold and dry environment in winters may actually help to preserve those viruses as they hop from host to host. All right, so now we're going to get into the lower respiratory system. And you can see in the lower respiratory system, we have different parts of the anatomy here. We have the bronchioles, which are these smaller pipes here coming off of the bronchus. And these lead to our alveoli, and these are little sacs here where blood capillaries and pulmonary veins reach to them in order to do gas exchange of both CO2 and oxygen. As you can imagine, this is a much more moist environment, and it can be a cozy environment for several different diseases to emerge. We'll be covering bacterial, viral, and fungal diseases here. We probably aren't going to get to all of these, but some that you should be aware of. So let's take a look at the bacterial first, and we'll start with pertussis. This causes what we call whooping cough. This is caused by encapsulated Bordetella pertussis, and they attach to the ciliated cells in the trachea. And as we have learned about the ciliary escalator in our first line of defense, that helps bring up microbes and mucus and flush it out of our lungs. So when pertussis binds to our cilia and inhibits the ciliary escalator, and it releases toxins as well, it shuts down that escalator and really puts us at a disadvantage of clearing the infection. There are different stages here. The catarrhal stage is a first stage here. It's a cold-like stage. Then you migrate into the paroxysmal. Excuse me, can't talk today. And this is an intense, violent coughing stage. This is the peak stage of the disease. It can last for months. It's most concerning for those with a weakened immune system. And yes, severe complications are possible. It can be quite scary. Then there is the convalescence stage, where this is a very gradual recovery here. And the disease can last for months. It's most concerning for those with a weakened immune system. And I think I already mentioned severe complications are possible, and that's why it's part of our DTaP vaccination. DTaP or Tdap, depending on if the first vaccine or the second vaccine, the booster vaccine that we get as a preventative measure. It's called whooping cough due to the violent coughing, the noise that people who have it make while they're gasping for air in this compromised lower respiratory tract, in part due to the binding to that cilia. Now, if this might be a part that you would like to mute your microphone, I understand that, but I think it's important as we understand how to diagnose and look for the signs for these diseases to associate the sound here. So I'm going to play this clip now of what it sounds like. So as you can see, that's where it gets the name whooping cough from, and why this is an important vaccination to provide to healthcare workers as well as children and those that are immunocompromised. Moving right along, we're going to talk about tuberculosis. This is also referred to as TB. It's caused by Mycobacterium tuberculosis. This is a slow growing bacterium. It has that waxy cell wall made of mycolic acids that makes it resistant to many antimicrobials. Once inhaled, it infects macrophages, so parts of our immune system, and it uses them as a place to multiply rather than being destroyed. Diagnosis is commonly done with a Montaut test, and this checks for an immune response to bacterial cell components, which indicates that you've had exposure to that organism. Treatment requires a multi-drug regimen, and this can last for 6 months to prevent resistance, and sometimes it just fails and it doesn't work. So TB is one of those bacterium that are really tricky to treat. It remains a global issue. There's over 10 million cases a year, so this makes it a persistent pandemic. As you can see here, the parts of the world that it's most common in, it's not so much of an issue here in the West, but in some places it has a pretty high prevalence. Pneumonia is often associated by Streptococcus pneumoniae, specifically the encapsulated strains, which account for about 2/3 of cases. The infection leads to inflammation of the bronchi and the alveoli, and this makes breathing difficult. Symptoms include high fever, chest pain, sometimes blood in the lungs due to fluid buildup. And with antibiotics, the mortality rate is still around 5 to 7%, and early treatment is key here before it gets too much of a foothold. A vaccine is available, protects against about 13 types of pneumococcal pneumonia, and helps to reduce the risk of severe infection. Moving along, let's talk about a few viruses common to lower respiratory system infections. Viral respiratory infections are often caused by enteroviruses. These can develop as complications of influenza, measles, chickenpox. In recent years, coronaviruses have emerged as a notable cause of this. Um, as we go through a few of these coronaviruses, we have SARS. This is called severe acute respiratory syndrome. It originated in horseshoe bats. It caused a major outbreak in 2002 and 2003, infecting about 8,000 people, killing another 900. You may have heard of MERS or MERS-CoV. This is Middle East Respiratory Syndrome coronavirus. It's thought to have come from camels. It has a high mortality rate, but it isn't easily transmitted between people. And then lastly, the one we're probably most familiar with today is COVID-19, which stands for Coronavirus Disease 2019. This was the year that the disease was classified as emerging. This is highly contagious. Its mortality rate is actually lower than MERS, But again, it's so highly contagious that this is where the issue really comes from here. Its origins are still being studied, but it did cause a global pandemic with widespread impact. Um, the flu is or influenza is caused by influenza viruses, namely type A and B, which causes seasonal epidemics, and type C causes mild non-epidemic illnesses. And they exhibit something we've called endogenic drift, where they can rapidly mutate as they replicate. And this changes the structure of those recognition molecules on the outside of the virion, and that allows it to evade immunity as it's constantly changing, requiring you to be get reinfected in order to gain new immunity to that virus, or a new vaccine must be made every year, trying to figure out how its new shapes of those markers are each year. There's a low mortality rate, less than 1%, but we have a very high incidence. So this leads to a large number of deaths, and it's especially a problem for the elderly and infants. Okay, now we've reached the end here. We're going to discuss fungal infections. We're just going to focus on this one here as it relates a lot to the American Southwest, coccidioidomycosis. We know it as valley fever or San Joaquin fever. It's caused by the fungus Coccidioides immitis. It's transmitted through inhalation of airborne spores commonly found in our soils. It can cause chest pain, coughing, fever, weight loss. It can become severe, causing these spherules full of spores to develop in our tissues. And its incidence is that it's an emerging disease here. It's growing in the Southwest due to drought and aging population, as well as just a growing population down here. And that comes to the end of our discussion of chapter 21 and 22, the skin and respiratory diseases. Like I said, this is going to kick off a bout of several more chapters where we're going to focus in on specific diseases of humans. Anyway, thank you so much for joining.